I appreciate the invite. I think this is maybe the sixth or seventh conference that I've been invited to, and I really appreciate it. I think just seeing real human faces out there in the audience is just refreshing to me in this time of Zoom. I even love the flight out here, like from Seattle, the short flight. The plane passes right over the LIGO facility. Do you all know this? The Laser Interferometer Gravitational Wave Observatory, the most sensitive device that has ever been made by human beings. This thing tests Einstein's theories of relativity by measuring the warping of space on the order of 1/10,000th of the width of a proton. Like an unimaginably small warping of space. And in doing that, it can detect the echoes of like black hole mergers and neutron star mergers across the cosmos. It's like mind-blowing to me. And then right next door to LIGO is the rest of the Hanford site, which I suppose goes without saying is sort of a reminder to me of the dangers to humanity and to the environment that our technology can cause if we use technology in a careless way, or we don't think enough about the implications of our technology. So sort of just an interesting little thought, at least for me coming over here. Medical technology has advanced as well. We have the ability to measure minuscule things. Some of the things that I will be talking about today are measured on picogram scales, a millionth of a gram of material. We can measure things on picogram scales in the lab and draw all kinds of inferences about the health of a human being. So this does present some challenges because as sort of as a wise old mentor of mine when I was in residency told me, we don't treat numbers on lab reports, we treat people. So that's sort of what today is all about. Obviously, I'm not here to sell you anything. I'm not here to convince you to buy any expensive med or anything like that. I am here to present a few scenarios that hopefully are common things that you may encounter in clinic as an adult healthcare provider. Common things that may test your medical decision-making skills or put you in challenging spots where making decisions and communicating with patients is a challenge, where we have to sort of figure out how to apply this technology to a human being that's in front of us. Okay, so if my homily here hasn't put you all to sleep after lunch, we'll get right into it. We're going to talk a little bit about the management of subclinical hypothyroidism, particularly for elderly patients or patients with heart disease risk factors. We're going to review the use of thyroid hormone for people with thyroid nodules. We're going to review the long-term management of patients with a history of thyroid cancer. And we're going to also review some recent safety data on the use of testosterone for men with hypogonadism. Now, in the syllabus, if you read the brochure, it also says that I'm going to talk about growth hormone. I don't have a whole lot to say about growth hormone, with the exception of that I recommend against the office diagnosis of adult growth hormone deficiency in almost all situations. I don't even have a slide that I prepared for it. I'm just going to say it right here unambiguously. I recommend against the routine office diagnosis of adult growth hormone deficiency. There are established clinical practice guidelines on this topic, but in my view and in the unanimous view of my colleagues at Virginia Mason, we feel that these are so contaminated with industry points of view and that these guidelines have so little discussion of side effects, long-term safety issues, and safety monitoring, and that these guidelines are written so in favor of treatment that they're basically not meaningful to us. So there, I've said my piece about that. Let's get that right out of the way and talk about things for which there's some ambiguity. All right, so I'm going to present a few cases to you. Case number one hopefully resembles the kind of patient that you may see a lot in a busy medical practice. This is a 77-year-old woman that comes in presenting for discussion of fatigue, for lack of energy. Fatigue is one of the most common complaints in a general medical practice. And for me, at least, fatigue is an ambiguous word in our language. So for some people, fatigue means sleepy. For some people, fatigue means out of breath. For some people, fatigue means weak. For some people, fatigue means sort of wanting to hit the snooze button a lot in the morning. For some people, fatigue means wanting to sit on the couch a lot in the evening rather than be active and do things. This particular patient describes fatigue as sort of an activity intolerance, sort of a resistance to being active, a feeling that if she were to try to be active, there's just not much forward momentum. She also reports forgetfulness and difficulty concentrating. She describes this as brain fog. Her past medical history is notable for hypertension and hyperlipidemia. She's on atenolol and pravastatin. On exam, her BMI is 29. She's mildly hypertensive, and she has a moderate high-frequency hand tremor. With labs, we see a mildly elevated TSH of 5.2 and a normal free T4 that's in the center of the normal range at 1.1. Everybody got that? Hopefully this resembles in some way some fraction of people that are coming into your clinic. So this is my question to you. If we were to prescribe this patient levothyroxine, if we were to add levothyroxine 100 micrograms a day, what would we expect to happen? Would we mitigate the higher risk of heart failure that's seen in patients like this? Would we lower her risk of mortality, heart attack, or cardiovascular death? Would we improve her blood pressure or lipid profile? Would we fix her fatigue? Would we improve her memory or cognitive function? Would we reduce her weight or body mass index? Would we have multiple benefits? Or on the other hand, would we normalize her TSH but do nothing else? Okay, more than one of the above. So this is not a board style question. This is not meant to test your diagnostic abilities right and wrong. This is meant to replicate the sort of thought process that probably goes on in your head when you encounter a situation like this, a patient with symptoms that suggest hypothyroidism, but with normal thyroxine levels and a slightly elevated TSH, what we call subclinical hypothyroidism. So let's talk about what the evidence has to show here. Let's address the first one. Oh my goodness. Hang on. Let's talk about the first one. Would we mitigate a higher risk of heart failure seen in patients with elevated TSH? So it is true that patients with hypothyroidism do have an elevated risk of congestive heart failure, as do people with hyperthyroidism. There's actually a U-shaped relationship between TSH and cardiovascular risk. So in the center of this graph, we've got the folks with the normal TSHs. That's our reference population. For patients with slightly elevated TSH on the order of 4.5 to 7, there is essentially no difference. That's this big black square right there. For patients with way out of range TSHs, either on the low side or on the high side, there's a clearly increased risk of congestive heart failure. For patients with kind of moderately elevated TSH, sort of the 7 to 10 range, there's a non-significant trend toward increased cardiovascular or congestive heart failure. So the particular patient in this vignette would sort of fall right in here with just a barely elevated TSH, no excess risk of CHF, nothing to treat. What about other things? Could we improve lipid profile or other cardiovascular disease? So here we have a meta-analysis showing a modest improvement in total cholesterol, triglycerides, and LDL for patients that have subclinical hypothyroidism, not even overt hypothyroidism. Over time, there does seem to be an improvement in plaque formation in the intimal thickness in patients that are taking thyroid hormone for subclinical hypothyroidism. So we've got these sort of like surrogate endpoints here. We can show improvement in cholesterol levels, improvement in intimal thickness on ultrasound, but are we improving outcomes? Unfortunately not. This is an interesting design of a study here. This study comes out of Denmark from their national healthcare system. And what they did was they took everybody in Denmark that has been diagnosed with subclinical hypothyroidism and looked at mortality. And what they actually analyzed on was the filling of thyroid hormone prescriptions from the pharmacy. So in Denmark, all their pharmacies are connected to their national healthcare system, and they can actually measure who is filling these thyroid hormone prescriptions, and does the filling of that thyroid hormone improve their expected mortality? The answer is no. Forest plot here. I'm sorry if this detail isn't projecting very well, but no benefit on heart attack, cardiovascular death, or mortality. So this is a recent sort of guidance statement published in JAMA a couple of years ago that suggests for patients that are over the age of 65, as the patient in our group was, that have a mildly elevated TSH, that treatment is not recommended. And this threshold here goes up to a TSH of 7. You'll remember from a couple of slides ago that above a TSH of 7, oh, here I did it again. Wrong button. For patients with a TSH above 7, there's this sort of trend, non-significant trend toward increased risk of congestive heart failure. And that's why in the guidelines, they sort of say consider thyroid hormone for patients with subclinical hypothyroidism at a TSH over 7. But for patients with a mildly elevated TSH, treatment is not recommended. So let's go back to our patient and the question that I asked. So we could improve her lipid profile. We're not going to improve any sort of cardiovascular outcome. What about all this other stuff? Can we improve the fatigue complaint? Can we improve memory or cognition? Can we get this patient to lose some weight? Let's think about all that stuff. And just to serve as a reminder, these were things that our patient was mentioning or that we observed during the visit. So here's a big randomized clinical trial that was published in the New England Journal of Medicine on this exact question for patients with subclinical hypothyroidism. Does giving thyroid hormone improve these things? Now, I normally don't show this sort of figure here, the flow diagram, because usually there's no great information for a talk in it. But in this particular study, they enrolled 2,600 patients that had an elevated TSH. And of those 2,600 patients, 1,600, nearly 2/3 of them, had a normal TSH when they rechecked. So let me say that again. 2/3 of the patients in this trial didn't end up having subclinical hypothyroidism when they rechecked, and they weren't even eligible for the study. So what that suggests for our patient in my vignette is that she's got a 2/3 chance of normalizing her thyroid function tests if all we do is wait and recheck. For the 1/3 of patients that actually had a consistently abnormal set of thyroid function tests, those are the folks that got enrolled in the trial or got randomized, either to placebo or thyroid hormone. Well, what did they find? Yeah, they definitely normalized the TSH. The TSH certainly came down with thyroid hormone replacement, but there was no benefit on the symptom scores, the hypothyroidism symptom score or the tiredness score. There was no benefit on weight, body mass index, waist circumference, blood pressure, or ADLs. So although they screened 2,600 patients, they only were able to enroll a small number of them. And so this study was not powered to address cardiovascular outcomes. They couldn't actually say much about whether adding thyroid hormone improved mortality or cardiovascular outcomes. But we should notice that the people that got thyroid hormone had a 2.7% rate of death, the placebo group about half that. So this study doesn't seem to be presenting much compelling evidence for improved cardiovascular outcomes. Let me just say that. So this is just one study. Actually, just another year later, JAMA came out with a huge meta-analysis of all the studies, 21 clinical trials in total, looking at all kinds of thyroid-related outcomes. So here's a forest plot of thyroid hormone treatment on blood pressure, basically showing no benefit. What about the symptoms of hypothyroidism? Here we see the overall general quality of life score in this sort of top bracket, no improvement. What about on the thyroid-specific symptom score? No improvement. What about the tiredness score? So fatigue is probably, for most providers, the single symptom that triggers thyroid hormone prescriptions, probably more than any other. The conventional wisdom is that if someone's tired, it's probably their thyroid. Thyroid is probably the first thing that many providers think of when they think of the causes of fatigue. Sometimes it's the only thing. This would suggest that for patients with subclinical hypothyroidism, this is not the solution. What about for depressive symptoms? Also, no benefit. If anything, a trend toward favoring placebo. What about for cognitive cognition? So the 4 trials that are in this figure assess cognition in 4 different ways, whether it was a memory test or the Folstein Mini-Mental Status Exam or other cognitive tests. Again, no benefit. And finally, for weight and body mass index, similarly, no benefit. Thyroid hormone was the very first weight loss pill ever tried back in 1894. The very first weight loss pill ever given. And it didn't go so well. In order to induce weight loss, often big doses of thyroid had to be given. That would cause lots of tremors and arrhythmias. You know, back in the time between 1894, when thyroid preparations first came to market, and 1958, when we could finally test TSH in the lab, there was this like 60-year period where we would treat presumed thyroid disease based on a clinical exam, symptoms and exam. And as you might imagine, when the conventional wisdom is that fatigue and weight can be improved by giving more thyroid hormone, that by the time that the TSH test came around in 1958, we learned that lots and lots of people were being overtreated or treated inappropriately with thyroid hormone. So, common trap. So back to sort of the guidelines here. For patients that are over the age of 65 and have a mildly elevated TSH, treatment is not recommended. For patients with a TSH of 7 or higher, yeah, go ahead. Now, what about the younger folks? What about patients that are younger than age 65 that don't have cardiovascular risk factors? So here we have a lot more to consider. And I think for younger patients that have a lower cardiovascular risk, younger patients tend to do a little bit better tolerating a little thyroid hormone than older patients do. If you have a patient who's planning pregnancy, if you have a patient who has multiple symptoms, if you have a patient who has anti-thyroid antibodies elevated or has a goiter, I would go ahead and consider treatment. So this is a bit of a problem because what I've just presented to you suggests that for the patient that we have in front of us in our hypothetical clinic visit, she walks in with all these symptoms, and I've just told you that thyroid hormone won't do anything about it. So That leaves us in an awkward position as a healthcare provider. We have this sort of zeal to fix things and to not be dismissive of complaints. Patient may walk in already having self-diagnosed with hypothyroidism based on online reading. And this may present a big problem. So I would submit to you that as tempting as it is to just write the prescription for the thyroid hormone and just be done with the visit, I would submit to you that it's actually a disservice to the patient to do that. Do people follow me? Because labeling these symptoms as being due to hypothyroidism denies the patient the proper workup for those symptoms that they deserve. It denies the thoughtful consideration of what really is going on. For this particular patient who described her fatigue as sort of an inertia, sort of an activity intolerance, not feeling like she can be very active, I would submit to you that taking the atenolol off and putting a different antihypertensive on is more likely to relieve her chief symptom than prescribing thyroid hormone. Do people follow me on that? So I think the key point that I'm trying to get across here is that as tempting as it is to just write the levothyroxine prescription, that's actually a disservice to the patient. Okay, I won't yammer on about it. Case number 2. This is a middle-aged woman that comes in for assessment of a thyroid nodule that was discovered incidentally on physical exam about a month ago. Between then and now, you got an ultrasound that showed a 3.5 centimeter nodule on the right lobe. And this patient's already had a needle aspiration. The nodule is benign. She returns denying the symptoms: dysphagia, hoarseness, shortness of breath, choking sensation, or pain. She's got no other past medical history, and her labs essentially show normal thyroid hormone. So just to give you the sort of the big picture here, thyroid nodules are quite common in the general population. If we were to ultrasound everybody, every adult, we would find thyroid nodules on about 1/3 of people in this country. So this too is a very common situation. Thyroid nodules are very common. The vast majority of thyroid nodules will not be a threat to a person's life. They will not be cancer. But there are 3 ways they could cause trouble. One way is by being a cancer, obviously. Another way is by producing too much thyroid hormone, by being an autonomous hot nodule. Her thyroid hormone levels are normal. The third way that a thyroid nodule could cause trouble is by getting so large that it causes local compressive symptoms in the neck. So my question to you is, if we were to consider adding thyroid hormone, 100 micrograms a day, what could we expect to do? Could we reduce the risk that the nodule will become a thyroid cancer in the future? Could we shrink the nodule? Could we improve her overall quality of life? Or none of the above? Now, if anyone here in this room is thinking C is the correct answer, I have just failed you in the last 10 minutes. Okay, so it's not C. And hopefully intuitively, we should be rejecting A as well, right? So the thyroid is not a particularly smoke-sensitive organ like the lungs. It's not a particularly toxin-sensitive organ like the liver. But the thyroid is an exquisitely radiation-sensitive organ. So iodine can be ionized by a broad range of radiation energies and can be turned into basically a free radical that damages DNA and causes mutations. The vast majority of thyroid nodules in people are completely random events. I mean, they could literally be as random as you getting hit by a cosmic ray at the wrong place at the wrong time. There are a few cases in which there are heritable causes of thyroid nodules, so benign multinodular goiters can run in families. The gene for that is known, but this is a person with a single isolated thyroid nodule that is almost certainly a random event from ionizing radiation. The only occupations that are associated with thyroid cancer are radiation workers and actually flight crews. So people that spend a lot of time up in the upper atmosphere get a lot of cosmic radiation and can be more susceptible to thyroid cancer. There is a small but statistically significant increase in thyroid cancer in downwinders that's relevant for all of you. I do have a few patients in my panel that lived in Eastern Europe in the mid-1980s during the Chernobyl disaster. And yeah, they definitely have a higher risk of thyroid cancer. Those folks often have extremely strange looking nodules on thyroid ultrasound, just really weird looking nodules. So anyways, back to the case. Depending on the time that you were in practice or received your medical training, you may or may not think that B is the correct answer. So what does the data have to say? This is a meta-analysis of 10 clinical trials of this exact question. Can we shrink nodules by giving more thyroid hormone? And the answer is no. So in this particular set of studies, the goal of the treatment, like the aim of the treatment with the thyroid hormone, was to shrink the nodule by 5 to 15%. So we're not talking about eliminating the nodule altogether. We're not talking about cutting it in half. We're talking about shrinking it by 5 to 15%. And I would submit to you that the patient is not going to perceive the benefit of that anyway. But even then, the failure rate is very high. The only studies that showed any kind of reasonable success rate had to give such high doses of thyroid hormone that they suppressed the TSH nearly all the way, caused a lot of hyperthyroid symptoms, and probably did more harm than good. So here we do have pretty clear guidelines. Don't do this. I know that a while back, the idea was to kind of like rest the nodule and shrink it down by reducing stimulation. Don't do that. Routine TSH suppression won't improve any outcomes for people with a thyroid nodule. And that once we've eliminated the possibility of cancer, and once we've demonstrated that the nodule is functioning normally, what we should be doing is giving reassurance. The American Thyroid Association does have pretty clear guidelines on assessing the risk of a nodule. And depending on how well you can see this, maybe from the front or the back, there's sort of a gradation of risk associated with this. On the bottom are nodules that are mostly cystic or filled with cyst fluid. Cyst fluid certainly takes up space, but with cyst fluid, there's no cells. With no cells, there's no cancer. As we get into solid nodules, or nodules that have particularly concerning features, nodules that have calcifications in them, or that are a very irregular shape, these are the ones that present the greater malignancy risk. There's also a more sophisticated scoring system called Thyroid that tries to distill all these things down into a point scoring system. And I would say that although this does do a good job stratifying which nodules need biopsy, at least at our institution, we find that some of these scores get really inflated by, let me just say, a zealous radiologist. Nobody wants to be the doctor that misses the thyroid, that misses the cancer. And so we tend to see that in our zeal to not miss things, we end up inflating the score and inflating the risk. The vast majority of thyroid nodules will not be a threat to a person's life or health. So a few concluding thoughts. If you encounter a thyroid nodule, the initial evaluation is an ultrasound and a TSH. If the TSH is suppressed, our best next test is to image the gland and see if the nodule is hot. A hot nodule is not cancer and needs no biopsy. If the TSH is normal or not suppressed, or if there's a cold nodule, we biopsy it. And the predictive value of a biopsy is actually quite good. The negative predictive value, the predictive value from a benign biopsy result is actually quite good. The likelihood that we have missed a malignancy is very low. Let's move on to case number 3. This is a woman that presents to your clinic to establish care after moving to the area. Her medical history is notable for thyroid cancer, which was diagnosed in her 30s. She got treated with a total thyroidectomy and radioiodine treatment. Since then, the follow-up's been kind of spotty. She hasn't felt anything, but there's this sort of lingering idea in the back of her head that in the time since then, things may have gotten out of hand and the cancer may have spread. So her past medical history, pretty unremarkable other than the thyroid cancer. Her review of symptoms is notable for a hand tremor and insomnia, poor sleep. She's taking thyroid hormone replacement, as she should. She has no thyroid gland left. She's taking 150 micrograms a day. Her weight is 62 kilos. Her BMI is 20, normotensive. She has no palpable thyroid tissue or lymph nodes in the neck. And her exam is notable for a moderate high frequency and tension tremor. Her TSH is 0.1, and her free T4 is a little bit above normal at 1.6. So this is my question to you. If we reduced this patient's thyroid hormone dose to 100 micrograms a day, what would happen? Would we increase her risk of having the thyroid cancer come back? Would we cause weight gain? Would we mitigate the risk of cardiovascular disease that's seen in patients like this, or none of the above? So this too is a scenario that you may encounter from time to time, maybe not as common as the first two cases, but it does present a bit of a challenge because we're balancing risks and benefits of multiple different things. So how do we determine, let me step back a little bit. When I encounter a patient in my clinic with a history of thyroid cancer, there's two questions that need to be answered. The first question is this patient free of thyroid cancer? And the second one is the thyroid hormone dose right? That's basically the two key questions that we have to answer. The way that we answer the first question informs our answer to the second. Patients that are higher risk for recurrence tend to get more thyroid hormone replacement to reduce that risk. So what do we do from here? For patients with a history of thyroid cancer, we classify them using this scale. Most patients with a history of thyroid cancer will fall into the top category, excellent response, which means that there's no clinical, radiographic, or biochemical evidence of disease. One of the advantages that we have in thyroid cancer is that we have a fantastic blood test, the thyroglobulin level, that is ultra sensitive. It is capable of detecting even microscopic amounts of thyroid cells, even in amounts that are too small to see on any imaging test. So this ultra sensitive blood test for thyroglobulin is an advantage. It takes advantage of a vulnerability in thyroid cancer cells that we can use to the patient's advantage. For patients that have an abnormal, a high or detectable thyroglobulin, or evidence of the immune system responding and making anti-thyroglobulin antibodies, we kind of conclude that there's some thyroid cells somewhere, but we may not know where they are. If we can't see them on any imaging test, we have to conclude that there's something there, but we don't know where it is. That's biochemical incomplete response. Structural incomplete response means that we know where it is. We can see it on imaging, and we know they have residual or recurrent disease. And sometimes we have nonspecific findings that don't really let us say for sure one way or another. We call that indeterminate. So what are the outcomes? For patients that have excellent response, their risk of dying of thyroid cancer is near zero. It is way less than 1%. And their lifetime risk of thyroid cancer recurrence is also very low. For patients that have a detectable thyroglobulin level, where we know that there's some thyroid cells in them somewhere, their disease-specific death rate is still very good. But 20% of them will go on to develop structural disease somewhere else. For people with known residual visible thyroid cancer that's visible on an imaging test, our outcomes are not quite so good. So many of them will have disease locally in the neck, but half of them will have distant mets, lung nodules, bone mets, mets in the skull, etc. And over half of these folks will have persistent disease no matter what we do. Additional surgeries or radioiodine will not be enough to render them excellent response. For people that are indeterminate, the odds are still in your favor. There's a very low disease-specific death rate, and only a minority of them will end up developing some sort of structural thyroid cancer. So it's really these folks right here, the folks that have visible, detectable thyroid cancer, that are the ones that have the highest risk of bad outcomes. If someone has gone 30 years, like our case, they got radioiodine 30 years ago, and they've been lost to follow-up since then, and they don't have nodes in their neck, they are very, very likely to be in this excellent response category. So our treatment should reflect that risk. For patients that have known structural incomplete response, we should be giving lots of extra thyroid hormone to suppress the TSH. Doing so will reduce stimulation of these remaining thyroid cells, reduce their growth rate, reduce the risk of progressive disease. On the other hand, for people with excellent response, there is actually no suppression of TSH indicated. Their risk of dying of thyroid cancer is near zero anyway. How are we going to take that and improve that risk? It's already near zero. For people that have indeterminate or biochemical incomplete response, we have to look a little bit deeper and think about their risk of harm from all this extra thyroid hormone, particularly for people over the age of 60, for people with low bone density, for people with tachycardia or atrial fibrillation. We need to be very mindful of the potential harms that that treatment may cause, because those harms probably outweigh the risk of death of thyroid cancer. I used to tell patients in my clinic that when thyroid cancer was treated properly, that they would have a normal life expectancy, that thyroid cancer need not shorten their life expectancy and need not take away from anything that they want to do in life. And then I came across this study right here that showed the opposite. This is a study out of Holland, again, another national healthcare system with certain advantages over our own, but basically looked at the death rate, all-cause mortality, and cardiovascular death. The blue curve is the control population, and the orange curve are the folks with differentiated thyroid cancer. These are the folks that I had been reassuring in my clinic. And as it turns out, there is a significantly greater mortality, both all-cause and cardiovascular, for people with thyroid cancer. So I've been giving people the wrong advice. It turns out that that increased mortality rate is not shared equally among all thyroid cancer patients. The lion's share of the increased mortality is in the people that get the most extra thyroid hormone, that have the greatest suppression of TSH. So here in this particular curve, they're taking all the thyroid cancer patients. They're sort of ignoring the controls for a second, and they're just taking all the thyroid cancer patients and stratifying them by their average TSH over the course of the study. The patients with no thyroid hormone suppression at all are this sort of gray curve on the top. The patients with kind of moderate TSH suppression, just a little bit of extra thyroid hormone, are in this blue curve, and the patients with full suppression of the TSH are in the orange curve. So the vast majority of the excess mortality is in the people that are getting way too much thyroid hormone. So you might look at this and say, well, wait a second, that's not fair. The people that are getting too much thyroid hormone are the ones that have the most severe disease. These are the ones that have the most aggressive thyroid cancer. They should be getting too much thyroid hormone. They should be getting suppression of their TSH. Well, after accounting for that, after adjusting for that fact, ironically, the cardiovascular death difference got bigger. And that suggests that there's a large number of people up there, at least in this particular study population in Holland, that were having excess adverse cardiovascular death from inappropriate extra treatment with thyroid hormone. So again, to go back to the guidelines here, the patients that have excellent response, this will be the majority of people that walk into your clinic with a history of thyroid cancer, don't need TSH suppression at all. The patients with the structural incomplete response, the people that have known thyroid cancer remaining in their body, or maybe to a lesser extent, the people that have biochemically detectable thyroid cancer should get some suppression of their TSH. Let's go back to the case. So this was a woman that came in noting a hand tremor, noting poor sleep, and had a TSH of 0.1 and an elevated thyroxine level. Her exam was notable for a moderate high frequency and tension tremor. So I would submit to you that this is a patient, if we were to verify that she were excellent response, which she probably is, that our next thing that we should do would be to lower that dose of levothyroxine. Normally, levothyroxine, thyroid hormone, is dosed sort of weight-based. We think about taking their body mass in kilos, multiplying times 1.6. That's a thyroid hormone dose. For a 62-kilogram woman, that's about 100 micrograms, roughly. So she is getting a significantly greater, she's getting about 2.5 mics per kilo per day, and she's manifesting the symptoms and signs of hyperthyroidism. So yeah, I think our decision is clear. Once we've verified that she is free of thyroid cancer, our goal should be to make her hormone levels normal. Okay, I've got a few minutes left, and I'm going to discuss a little bit about testosterone therapy for men. So a big change in topic here. Let's talk about case number 4. 65-year-old man that comes in for review of an abnormal bone density test. He had suffered a low trauma fracture. He slipped in the shower, he fractured his arm. And during the repair, his orthopedist told him that his bones felt thin and weak during the repair of the fracture. The patient notes over the last couple of years, he's noticed a reduction in libido, difficulty maintaining adequate erectile function. His muscle mass and strength are modestly lower, and he feels a little bit more deconditioned. His mood has been slightly depressed. His past medical history is important. He has cardiovascular disease. He had an angioplasty 5 years ago. He has cardiovascular risk factors, hypertension, sleep apnea, and hyperlipidemia. He tells you that his sleep apnea is fairly well controlled. His dad had a CABG at age 50. On review of systems, we have weight gain. He's taking lisinopril and atorvastatin. His exam has a few important things that I want to discuss. He appears virilized, which means that he has a normal adult male secondary sex characteristics. He has some modest recession of hairline at the temples. He has facial hair in his jawline and sideburn area. He has male musculature. And in particular, when I think about that, I look at the axial musculature, the sternomastoid muscles and the trapezius. And these are sort of some of the most testosterone-dependent muscle groups in the body. He has fatty enlargement of the breast bilaterally. So some people call this pseudogynecomastia. Some people call this lipomastia. But basically what it means is that there's fatty growth of the breast tissue without glandular growth. Now, let me dwell on that for just a second so I make myself clear. The normal male mammary gland is a nickel or dime-sized, thin, firm disc of tissue that is concentric with the areola. Nothing enlarged or eccentric. His testicular exam was basically normal. His morning total testosterone is slightly low, and he has osteoporosis of the femoral neck. So, What advice is most appropriate given his history of cardiovascular disease? Either A, prescribing testosterone is not recommended due to the higher risk of heart attack and stroke. Is it B, testosterone therapy would not increase his cardiovascular risk and be prescribed right away? Is it C, before prescribing testosterone, we need to confirm the diagnosis of hypogonadism and we need more safety information? Or D, referral to online men's health clinic is most appropriate? Now, I know that a lot of you are thinking D in a context of a busy clinic because this is not always a conversation that we enjoy having with patients. There's a lot of pressure exerted by patients on us to prescribe. And I think we have this sort of idea in our heads about safety not being in the best interest of the patient. So let's think about A and B. Why is this diagnosis so tricky? Well, testosterone levels fluctuate quite a bit during the day by a factor of 2. Testosterone is a difficult substance to measure accurately. It's oily and sticky. It sticks to plasticware in the lab. Testosterone is bound to SHBG, sex hormone binding globulin, and changes in this protein can totally screw up the results of the total testosterone level. And of course, there's controversy regarding the benefits and risks. So this is just what I would suggest to you in terms of pearls and pitfalls. I recommend against checking testosterone out of curiosity or for non-specific symptoms like just fatigue or because somebody heard an ad on the radio. That's not a great reason to check a testosterone. You are more likely to get fooled than you are to get to a proper diagnosis. So particularly for people with anemia, with men with anemia, osteoporosis, infertility, gynecomastia, or a pituitary tumor, definitely check testosterone. The more specific symptoms would be loss of libido, erectile dysfunction, and somewhat less specific loss of muscle mass or decreased body hair. There's a few issues in testing as well. I recommend checking morning testosterone levels. That's when it's most informative. And what we're looking for is reproducibility. We're looking for consistently low testosterone levels across multiple times of testing and at baseline health. If I get a pneumonia and land in the hospital, or if I develop some acute medical illness, my testosterone level will go down. Does that mean I have hypogonadism? No, not at all. We want consistent low levels at baseline health. There are other situations in which the total testosterone will be erroneous. Men with obesity, diabetes, insulin resistance, men with nephrotic syndrome or taking glucocorticoids. There we should be checking a free testosterone, and this is a very, very tricky test. We're talking about picogram quantities of testosterone, a millionth of a gram. And here there are only a few labs around the country that can measure this substance accurately, the free testosterone. At Virginia Mason, we use Mayo Clinic. I would recommend strongly against using local labs that provide a direct free testosterone measurement. The accuracy of that is about the same as the flip of a coin. So yeah, don't do the direct testosterone measurement. What are the potential causes? An otherwise healthy man shouldn't just get hypogonadism out of the blue. There should be something else going on, although often we don't find it. There may be anatomic lesions of the pituitary. There may be other underlying endocrine disorders. But most likely there is something that is suppressing the gonadotroph cells of the pituitary. Most patients will be somewhere down here. They're taking opiates, they're taking long-term glucocorticoids, or they have some other acute medical illness that's suppressing the gonadotroph function. There can be primary hypogonadism too, people that have injury to the testes, physical or chemical injury, infectious. Most of the congenital or genetic should present in different ways than this patient. What are the beneficial effects of testosterone? The biggest ones are on bone density and anemia. Those are the biggest, clearest benefits of treating hypogonadism. There is moderate benefit in sexual function and mood. There is questionable improvement in executive function, cognition, and fitness. Potential harms: prostate, erythrocytosis, sleep apnea, and then let's get quickly to this recent clinical trial in New England Journal of Medicine on cardiovascular outcomes. This is sort of the last of the talk here. Large trial, 5,200 patients of men with pre-existing cardiovascular disease. They could have had a distant angioplasty or bypass and had hypogonadism. This is a confirmed, consistent, low total testosterone level. Randomized to placebo or testosterone gel with a 4+ year follow-up. It was adequately powered to look for a difference in cardiovascular events. No difference was found. So at least for this particular patient, this patient's history of an angioplasty or cardiovascular disease and risk factors, this patient that we're just talking about here in this case would have been eligible for this clinical trial, and his cardiovascular disease would not be a contraindication to treatment. And his osteoporosis would actually be a significant benefit of testosterone replacement. So I am out of time. I appreciate all of your attention. I hope I've covered a few things that are at least common for you in your practice. And once again, I appreciate the invite.
Question on the woman with the history of thyroid cancer. Do you normalize the TSH before you check the thyroglobulin, or just do it all together?
Once I verify that that patient has what we call excellent response, undetectable thyroglobulin level, nothing apparent on a neck ultrasound, I can conclude that that patient has a near zero chance of dying of thyroid cancer and a near zero chance of recurrence in her lifetime. And my goal should be to just make that TSH normal, allow it to rise into the normal range. Yeah. Question down front here. Yeah. Have I heard of a patient who was born with enlarged adrenal glands and no sense of smell? So we were talking a little bit in one of the last slides about causes of hypogonadism. Causes of hypogonadism. One of the things that's not on here is a disorder that involves the sense of smell called Kallmann syndrome. Kallmann syndrome is a disorder in which many midline structures, including the pituitary gland, don't develop very well. So that can occur in males or females. And so someone with hypogonadism and no smell could be that. Adrenal hyperplasia is a different thing entirely. Yeah.
Okay, my question is, my name's Rhonda.
Oh, hey.
Hi. Hey, the big craze right now is pellet therapy, with hormonal replacement. And over the last couple of months, I've had patients come in and they want to transition from the pellet therapy in which they're getting estrogen. Some males are getting estrogen, progesterone, and testosterone in their pellets. And due to cost, they want to just transition over to an injection form. I don't know what test to draw, if it would be a direct or a free testosterone. Do I still look at their FSHs, or where would I begin?
Yeah, so this is kind of the Wild West here, where there's a lot of men going kind of outside the traditional healthcare provider system. And this is almost sort of like retail medicine now. I would just say that this is kind of what happens when traditional healthcare providers aren't quite as forthcoming with strong medical advice. When there's this sort of information vacuum, people sort of go other places and hear other points of view. Obviously getting pellets of estrogen, progesterone, and testosterone, at least for me, it makes no sense at all. And I would probably have a bit of a hard time saying that in a polite way. Either way, if we take a guy who has a clear diagnosis of hypogonadism, our goal of treatment is the same. All we're trying to do is make the testosterone levels in the normal male reference range. We're not aiming for Jason Momoa testosterone levels here. That's a good way to get bar fights and sexual harassment lawsuits and road rage incidents and things. All we're trying to do is get a testosterone level in the normal range as safely as possible. And that's what it really boils down to. It doesn't matter what route of administration, whether it's gels or injections or pellets or oral testosterone or whatever. The goal of treatment is the same. Oh, you mean like as the pellet sort of wears off and now you're sort of cross tapering onto another treatment modality? I think that the instinct here would say start at a low dose and up titrate slowly. Because I think if we're stacking another treatment onto a pellet, we have a very high risk of overtreatment. Yeah.
There's a virtual question here. Is there evidence of cholecalciferol influence in thyroid dysfunction?
Of calcitriol.
Yeah, cholecalciferol influence.
Say again, please.
Cholecalciferol influence.
Cholecalciferol, vitamin D.
Yes.
So there is no direct effect. Cholecalciferol is vitamin D3. That's the kind of vitamin D that comes from animals. Ergocalciferol, vitamin D2, comes from plants. Both of them are vitamin D. And 1,000 IU of cholecalciferol is the same as 1,000 IU of ergocalciferol. They do the same thing. Vitamin D deficiency is incredibly common in our patients. I could walk around in a bathing suit all day in Seattle and not make enough vitamin D from the sun. And given my lactose intolerance, I probably have a very high risk of vitamin D deficiency. But that doesn't have a direct effect on my thyroid function.
I have a patient who was in the low 200s testosterone, the AM total testosterone. It was normal, low normal, but he wants to be in the 700s. Yeah. What do you recommend?
Tricky conversation. So for men that have a testosterone level that is in the normal range but lower than desired, this can be a really tricky conversation. I would focus on the symptoms that are leading to that conclusion. Is this just somebody that wanted to test out of curiosity, had no symptoms, and was dissatisfied with the number on the lab report? I think here again that returns me to those wise words from my mentor, that we don't treat numbers on lab reports, we treat people. I would focus on the symptoms, if any, that led someone to that conclusion, and not be in a rush to label those symptoms as being things that I'm going to fix with more testosterone. For many patients in that situation, if we were to prescribe testosterone, we can make the number on that lab report get bigger. But a few years down the line, if that patient were ever to stop the testosterone, he would notice that the symptoms are worse than they ever were because he has become physically dependent on the treatment. And that we're actually causing the very disorder that we set out to treat. Do people follow me on that? Am I being too verbose here? Yeah, okay.
Question. When I was working at the prison, I had an inmate that definitely had thyroid cancer, no doubt about it. It was taking forever for us to get him in for surgery. So in the meantime, internal med suggested that I add some thyroid replacement hormone to help suppress the thyroid. And he did feel better. He said he could swallow better and everything. Finally got him into surgery, but it was just kind of a stopgap. Is that okay?
These are tricky situations. So the biggest predictor of long-term success in thyroid cancer is surgery. Is having a prompt, complete surgery. That is by far and away the biggest predictor of outcomes. After that, the next biggest predictor of outcomes is having a proper treatment with radioiodine if eligible. Excess thyroid hormone can reduce the TSH, can reduce trophic stimulation on thyroid cells, including cells of papillary and follicular thyroid cancer. But the magnitude of that benefit is going to be very, very small compared to surgery and radiation. So if you're in a situation like that, pick up the phone and call someone and let them know what's going on. Yeah. That's unfortunate. Yeah, that's unfortunate. Other questions? Thank you all.